Last night I met with Samantha Greenberg, the founding program director of the UT Southwestern Genetic Counseling Training Program. We had more in common than I realized because she recently received her PhD from the University of Utah. Her dissertation focused on the question, what are the basic frameworks required to incorporate genetic services into a learning health system? She leveraged EHR data to gain insight about the proportion of eligible people receiving referrals to genetic counseling, and then investigating how many of them show up to the appointment and learning why or why not. She also worked at the Huntsman Cancer Institute, which is nestled with the rest of the Health Sciences campus at the University of Utah in the foothills of the Wasatch Mountains. I spent a lot of time as a PhD student living in student housing in that location, hiking and biking in the foothills, and took phone calls while walking in the trails when I could. The concept of a learning health system was established nearly 20 years ago as a unifying commitment to speed the translation of evidence to practice. Here's a case study that really illustrates the LHS cycle, led by an interdisciplinary team at the VA. The team analyzed VA data to show that if you increase the adenoma detection rate in colonoscopy exams by 1%, death from colorectal cancer decreased by 5%. That insight showed the potential benefit of helping gastroenterologists identify adenomas better during colonoscopies. So how do you do that? The solution that was chosen was to start auditing colonoscopy quality metrics, including adenoma detection rate, or ADR, because you can potentially change what you measure. However, that required manual audit across the nation. Moreover, once you estimated the ADR, there was no formal improvement plan to improve performance. This is where I came into the picture. I worked with this team to develop NLP algorithms for identifying quality measures without the need for manual audit. We were able to show that there was substantial variability in colonoscopy quality across sites. This time, the solution for translating knowledge to practice was an automatically generated report card across the VA that they showed was accurate and usable. Still, you need a way to act on the insights from the data, so they created a learning collaborative to support physicians with lower performance and a quality dashboard to show improvement. A clinical trial showed that this intervention reduced colorectal cancer death. People adopting the LHS model have demonstrated several ways to operationalize it. This new commentary describes 4 distinctive models that have evolved as learning health system activities have matured. First, though, I have to say something about the first author on the paper, Chuck Friedman. Chuck has been an international champion of the learning health system, and I have a warm place in my heart for him. He recruited me and Brian to Pittsburgh as postdocs in the year 2000. He went to the office of the national coordinator and then founded the Department of Learning Health Sciences at the University of Michigan and is the founding editor of the journal Learning Health Systems. The first type of LHS is the example I just told you about in the VA. Improvement cycles targeting specific health problems led by learning organizations or learning communities. This model requires extensive technical infrastructure such as access to data and ability to build solutions that fit into the healthcare delivery system. Consumers are partners in this model, and as I discussed in last week's video on quality improvement, knowledge and motivation to do this has to pervade the culture for it to be effective. The second type of LHS is one where researchers are embedded into the health system to help generate real-world evidence about programs that are being put into place to improve care and outcomes. This requires functional relationships between a health service and the scientific community, the ability to analyze data from practice, and funding for the researchers that meets their career requirements, but also fits with the health system's funding model. An example listed in the commentary is one many of you are familiar with, the Texas Health Resources Clinical Scholars Program, where diverse scholars are embedded in and working with THR. The third type of LHS involves running pragmatic trials, rapid cycle, randomized, real-world trials that compare different interventions during regular process of care. We've performed some of those pragmatic trials here at UT Southwestern, and it requires the technical infrastructure to randomize clinicians or clinics to different interventions, tight governance selecting which questions to address with this method, and statistical expertise to determine when one intervention is better than another. Vanderbilt has a pragmatic trial LHS program where they help people set up, execute, and analyze this rapid cycle A/B testing. The fourth type of LHS is programmatic. These are large, publicly funded programs meant to support data-driven healthcare improvement and development of shared infrastructure. They require a lot of coordinated funding for national and international networks and infrastructure to support shared data models, for example. This brings me back to Dr. Greenberg and her passion. The genomics-enabled learning health system is an example of an LHS program that is meant to help health systems capture genomic information from every patient encounter, generate evidence that can enhance clinical decision-making and patient outcomes. The commentary concludes that all of these models undertake improvement through rigorous methods of discovery, leading directly to the implementation of what's discovered, which is my vision for my role at UT Southwestern. One of the fun things about moving to Texas and buying our first truck is seeing the dogs poke their heads out the window when we go on field trips, like Saturday to the Arbor Hills Preserve, where Kari got not only wind in his hair, but scratches and loves.